clinical instructors. So I guess I just wanted to touch base with you about clinical. I asked this yesterday, and I kind of want to follow up again, just because I didn't hear a lot. Do you feel comfortable from clinical about moms and babies for postpartum? So.
I've only done one day of other babies, so I'm doing my next.
That's helpful to know. So I guess, because this will help me target what I need to work on for Tuesday rather. So if we did postpartum mom, I hate this marker, baby. Like, what do you have questions about for moms? Nothing? Or baby? My question is, are there concepts or things that you are fuzzy on because you're either not seeing any clinical because of your experience, like things you're fuzzy about, or things that are causing you duress, like you don't know about it, or something that needs further explanation, or something that I would want to make sure that I address on Tuesday before the test on Thursday. Is that a better way to frame that question? Okay, well, we'll come back and visit that. So, Tuesday might be a short day. So, that's all right. I'll just throw up some random, I'll put up some random questions and we'll see what happens. Maybe that'll trigger other questions. So, Tuesday's very informal. There's no PowerPoint for Tuesday. What I usually do when I do that review session is I do a lot of review questions. I'll do a combination of some short answer things as well. And then I usually pull the worksheets from orientation to make sure there's nothing on that worksheet. Drug cards are another big thing because a lot of people forget about the drug cards for postpartum and newborn. And then, yeah, I think that's pretty much, again, it's not that it's hard, I think it's just a lot, and again, it's kind of focusing on mom and baby. And some people are very interested in baby, so they study all the baby stuff and they forget about mom, and vice versa. So maybe over the weekend we'll see. If you have things that you specifically want me to talk about on Tuesday, you would shoot me an email. That would be helpful. So that way I can make a good use of your time. So.
Are we going to know the meds? Because we haven't gotten any of our med cards back from clinical. So we have to study those. I need to ask to get them back.
So what I would know is in regards to your medications, who gets it, why do they get it? And are there things that I need to teach your patient about that particular medication? So I can send an email to the clinical instructors and say we need your drug cards back before the exam. So.
I don't want to have time to look at all of them.
I don't want you looking at, it's not good use of your time.
No, that's what I'm saying. It's kind of a new point.
I think about the drugs that we use a lot. So for example, in the newborn, you should be very comfortable with the rifamycin, vitamin K, and Hep B vaccine. Narcan less so. All right. So I'll make sure and hit meds pretty hard on Tuesday if folks are missing their drug cards. Okay. When last we left, we had finished up with withdrawal, and we're now going into cold stress in the newborn. So cold stress tends to be a phenomenon that we're going to see more in the first day of life. We don't generally see it later. However, if you are premature, it can go beyond that first day because, again, premature babies just don't have the means to maintain their temperature. The other thing that we can see is with exposure. So, for example, if you have a family who is homeless and they're outside in this type of weather, you might have a baby who comes in through the ER in cold stress because of exposure. So when the baby gets cold, what happens is that the metabolic rate increases to try and increase and meet that temperature. That increases your oxygen demand. You have peripheral vasoconstriction, which you're probably familiar with. So when you're cold, you'll notice sometimes that your fingertips and things turns blue because you're trying to, again, conserve. And then you also, in the newborn, have pulmonary vasoconstriction. Remember, that is the opposite of what should be happening. You should be having pulmonary vasodilation. There is this phenomenon in newborns called persistent pulmonary hypertension, and that is where you have kind of that high pressure in the lungs, which was in the fetus. It continues in the neonate or newborn, and we don't want that. So in other words, I do not want this to occur, and you'll notice in this particular graphic, it shows that supply does not meet demand, and so that's where you see hypoxia. So temperature regulation is a big deal. It is something that whenever you're doing vitals on a baby, I would certainly get temp, pulse, and respirations. So we want to look at babies who are at high risk of hypothermia. Hypothermia would be a baby who is SGA, IUGR, has very little sub-Q fat, doesn't have that brown fat, so a preterm baby would be more at risk for hypothermia. You also want to think about where they deliver. So if somebody delivers at home, on the side of the interstate, in a cold OR, those are babies who are going to have more risk with their thermal regulation. Generally, when we assess a temperature for healthy babies, normal babies, we'll do an axillary temp, and then depending on the protocol at your facility, if that axillary temp is outside of parameters, we'll do a rectal temp. Has anybody done a rectal temp on any other babies? Yes? Yes? Kevin, I'm afraid you're a baby expert, sounds like. We keep going to you for baby stuff. What was your baby's record? Did you know why they did a rectal temp?
Yeah, the Baptist policy is like when they go down to the nursery.
They always do a rectal temp. And so we don't generally teach parents how to do rectal temps anymore, and it's because we do other things. So axillary and tympanic and temporal and things like that. The other thing is we don't use mercury thermometers anymore. The glass, they can break and things like that. If somebody is going to do a rectal temp on a baby, it's really important that they know that if they do a rectal temp, it only goes in a very small amount. It would not be like an adult. So again, very small amount there. Don't want to perforate the rectum when you're trying to do a rectal temperature on a newborn. I've seen some nurses, folks, their thought was, oh, we'll do a rectal temp on the baby and that will cause stimulation of meconium, and that will get the baby to poop and pass meconium. And I don't think that's supported in the literature. So I think it's one of those things that kind of an old wives' tale, but I'm not really sure it does what people think it says it would do. We would assess labs, and remember with temperature, one of our concerns is sepsis. So I would want to know maternal history, GBS status, how long she was ruptured, did she have any STIs, sexually transmitted infections, did she get antibiotics when she was in labor, what's mom showing us? Because a lot of times if the baby has problems with sepsis, mom also has problems with sepsis. So if mom's septic, they're probably going to work the baby up for sepsis as well. With hypothermia, babies are kind of pale. They have that mottling. Does everybody know what mottling? It looks kind of like lace-like. You see all the vessels. That's not normal. We should not see that all over the whole body. Sometimes when they're cold, if we warm them up, that goes away. But these are babies who are not eating very well, they're lethargic, and we can see, again, respiratory distress with those babies. So this is the term that our textbook uses called neutral thermal environment. And so all that means is that the air around the baby needs to be warmed. We want to look at the 4 mechanisms of heat loss and prevent heat loss through evaporation, conduction, convection, and radiation. When you are taking care of a baby, obviously, we only uncover the parts we need to look at. So I don't take everything off the baby and do a head-to-toe assessment and then put everything back on the baby. I can keep the t-shirt on. I just lift the shirt up, look what I need to do, put the t-shirt back on, keep the hat on the baby, things like that, just common sense. When a lot of moms think that babies need baths every single day, and actually they'll say, well, why hasn't the baby gotten a bath? So what's the policy at your facility about when new babies get a bath? Or is there a policy?
After 6 hours, unless their blood sugars aren't good, they have to have 3 before.
Okay.
3 good ones before
Okay.
they get them.
So 6 hours, but if you're hypoglycemic, you wait even more.
That's 12 at Baptist.
12 hours at Baptist. So again, there's a movement toward getting, and that used to be one of the most fun things that people were so about. And what they have found actually is that that often causes problems with temperature in the first 24 hours. Believe it or not, in the UK, you know how we only do sponge baths, and we don't do tub baths until what? the cord's fallen off, circ site's healed, all of that. They actually do tub baths on babies in the UK, new babies, and they have found that their temperature loss is actually less. You think about it, if you're cold and you are in a nice submerged water, right, you're better, and again, that's where they came from, because they were submerged in water. So, I think there's some potential developments there. The reason we are kind of about tub baths, temperature was a big one, which we're not sure that's still true, but infection, and if there were pathogens in the water, and it, you know, those pathogens might get into that umbilical cord site and cause infection, and all that, so. But I think a lot of parents are surprised by that. Maybe their first child, the baby got a bath right away, but now you're at the hospital and you're saying, oh, the baby's not gonna get a bath for 12 hours. So you might have to do some teaching with your parents about why we delay the bath, and it's to prevent cold stress, okay? If you've got a baby who is not responding to typical treatment, which is usually a radiant warmer, isolate, we can provide warmed O2, and then we can also do IV fluids and gavage feedings for those babies that are poor eaters, and it has to do with sugars, kind of making sure because they're not able to eat and maintain, they can't do all those stressors all at one time, so we support them physiologically. So hypoglycemia, with hypoglycemia, these would be examples of nursing diagnoses for your baby. So altered nutrition, less than body requirements, risk for injuries related to decreased glycogen stores, and then risk for birth injury related to the size of the baby. In terms of hypoglycemia in the newborn, it is a priority in the first day of life. It is less so later. Once the baby's eating, so I'm really worried about sugars initially, but I don't have to keep checking sugars very long. As long as the baby's eating. Now, if the baby's not eating and starts to show us signs of hypoglycemia, we might check a blood sugar. But quite honestly, if the baby's jittery around day 3 and the baby's been eating, my first thought is not hypoglycemia, it's withdrawal. So generally, once the baby's eating, sugars start to come up and things are good there. But definitely the first day of life. So do you know what the magic why 3?
I have no idea.
Yeah. And I don't know either. Is it 3 within a certain time frame?
I think it's before feeds. I think it's just any time before the baby gets fed.
Yeah, because they want to know what's the potential lowest point the sugar is. And it's the concern that you don't have enough in reserve to handle the stressor of the bath kind of thing. Some places it depends on the size of the baby. So for example, if you've got a baby that's over 9 pounds, 9.5 pounds, 10 pounds, they'll do blood sugars on the baby because that's a baby who's more at risk. We're gonna see hypoglycemia in preterm babies more than term babies. So you have to think about what's going on with your baby. Certainly we wanna also look at the respiratory status. So if that baby has tachypnea, are you okay with that term? Fast respirations. Bradykinin is slow respirations. Depending on how old they are, the O2 sat may give us some data, that's good, but may not. If I do the O2 sat really early, remember it takes a little bit of time for that to get kind of above 90%. But with that respiratory status, I'm looking at other data. So I'm looking at nasal flaring, use of accessory muscles, they're breathing really hard, they're grunting, they're making noise, that sort of thing. So same thing as what we talked about with cold stress, neutral thermal environment. Usually we do a glucose by heel stick, so it's not a venous stick. You don't have to try and get in those little baby veins. Anybody had a baby get an IV? That's good. So in terms of IVs, we don't like to put IVs into babies, but IVs will be in a variety of spots. They might be in the anteubral space, they might be in the foot, they might be in the scalp. If it's a really, really sick baby, sometimes I actually will use the umbilical artery and I'll use access through that, okay? But again, for our babies that we're talking about, they're usually, if they have an IV, it's usually either brachial or in the foot. So you wanna make sure these babies are eating frequently, early, and then we often check the glucose level because you wanna make sure your intervention is working. So I would wanna make sure that these babies, they keep their glucose above that 40 to 45. So if I got a blood glucose of 55 on a baby, I'm really happy with that. If I got a glucose on mom of 55, I would be really unhappy. I would do something about that. So you could see this in a big baby, you could see it in a little baby. You could see it in a preterm baby, you could see it in a baby born to mom who had diabetes or problems with We could also see it in a baby that had stressors at delivery. So term, normal, healthy, but if the baby had stress at the time of delivery and is not adapting well to extrauterine life, their sugar drops. Okay? So that's why I'm always watching for it, I'm always screening every baby for it. Hyperbilirubinemia is the big long phrase for jaundice. So remember with jaundice, we would anticipate seeing that in term babies right around day 3 of life, okay, kind of peaks right there. We see it in more preterm babies than term babies. But again, almost half of term babies will have a little bit of jaundice in them. So these are babies who have high enough jaundice that warrants an intervention. And so they have to be under the lights. And so that's what phototherapy is. It's ultraviolet light. When you have a baby that's under phototherapy, you want to make sure that you're looking and seeing what does their skin look like. And again, you may have to blanch and look for the color change, so it's best to do that under bright light. You're looking at the mucosa, the sclera. In a child that has darker pigmented skin, it may be more difficult to make that skin assessment. The other thing that guides us about phototherapy, quite honestly, is the serum levels of bilirubin. And remember, we're trying to go from unconjugated to conjugated bilirubin so that you can excrete it and get rid of it. So when a baby's under phototherapy, the bilirubin level should be declining. If it's not, that's very concerning. So what's the big hullabaloo about bilirubin? If it gets too high, it actually can cause brain damage. It's toxic to the brain. Now, when you have a baby that's getting phototherapy, if they're under a bank of lights and in an isolette, we actually can feed the baby in the isolette under the Billy lights. Some of you may have seen Billy blankets. Billy blankets are nice. The baby kind of wears this kind of, almost looks like the Michelin Man with the tires, you know, and it's kind of all these bright glowy lights, and it allows you to hold the baby so that way the baby gets that sensory stimulation, feel more comfortable with it, and again, you get to spend more time with your baby. When babies are in Billy lights, sometimes you kind of feel like you can't touch them. It's like they're a museum exhibit or something because they have these really bright lights on them. Whenever you have a baby under the banks of Billy lights, we have eye protection. If they're wearing the Billy blanket, they often don't have the eye protection, okay, because that can hurt their eyes. The other thing, when you have a baby in an isolette with Billy lights, we don't want any type of t-shirt or anything on the baby. We need that skin exposed as much as possible, so the light helps us turn that unconjugated bilirubin into conjugated. So that's why they're in the isolette, because we can't just have them out to environmental air with no t-shirt on, just a diaper on. So they're often in an isolette. Try and keep that maybe around 37, 1-ish, you know, Celsius or whatever. And then your Billy lights. And again, with Billy lights and the baby, we often again kind of turn and reposition that baby frequently, kind of making sure there's as much exposure as possible to that light. In some babies, you will see that they'll only be under lights maybe 24 hours, which is nice. Sicker babies need longer. And with babies who are under lights, we want to make sure we weigh them daily, that they're getting enough fluid intake. We certainly don't want to see a seizure. A seizure would be a red flag for us to say there's too much bilirubin. And when I say bilirubin, like kids who have really high bilirubin levels, it's like 20 or 30. Okay? Most of the time for our babies that we're seeing, you might have a Billy that's maybe 9 or 10 or 11. You know, it's in those kind of lower ranges. So. With skincare, it's really important to monitor because baby skin is very fragile. You would not want to have any kind of ointments or anything shiny because that Billy light could cause a burn or skin breakdown on the baby's skin. Sometimes people are well-meaning and they put a lot of junk on baby's skin. Babies don't like it. It's kind of fragile. It kind of disrupts their skin. The other thing you'll notice is people who are real, what's the right word? I don't know, aggressive is the only word I can think of, with baby wipes. So in other words, they're using a lot of baby wipes and they're wiping lots and lots and lots. It sets the baby up for dermatitis, contact dermatitis in their genital area. Temperature, again, you have to monitor that as well. And it's just like, it's all interrelated. So again, I'm watching for hypoglycemia, I'm watching for nutrition, I'm watching respiratory status. So if you kind of know one, you kind of know them all. And again, we generally would focus on this, and and our babies that we're talking about around day 2 or 3. Now, if you have a baby that has pathological jaundice, okay, pathological jaundice is very bad, very high. Babies have this, but they generally are going straight to NICU. Okay. All right, so parental attachment. With parents who have babies in the NICU, we want to try and encourage skin-to-skin contact and make sure that the baby has that time and opportunity. Communication is really important. A lot of times there's team conferences because you'll have different disciplines. So you might have respiratory, you have nursing, you have a neonatologist, you might have speech pathology there for swallowing. You also might have infection control there because depending on what type of infections the baby's having, you might have a pediatric nurse practitioner, because these are babies sometimes who will have long-term and need long-term care management and chronic care management after they're discharged from the hospital. NICU parents love talking to other NICU parents. It's just like, cancer patients and families love talking with other people who have lived that story. So it's really helpful to get them connected. It's always a lot of fun when you have big, parties and you see kids come back that were in your NICU and now they're 5 and 6 and they're running around. It's fun. You see, and it's funny because, some people really remember the nurses who took care of their babies. And I mean, they really, because you were there in the worst times and the best of times. And there's nothing better for a NICU nurse than to send somebody home. That's what your goal is to get them to go home and spend time with their families. Lots of teaching, and I think one of the things as I would encourage you to consider is that we have to repeat ourselves a lot because you have somebody who just had a baby. So you can't be judgy like, well, I told her not to take the hat off the baby. Forget, you have kind of that postpartum mind. You also are under an incredible amount of stress because your little baby is sick. So we have to say things a lot. We need to be really understanding. You have people who are sleep deprived and sometimes they take it out on us as nurses. So you kind of have to be thick-skinned a little bit and just kind of help people cope appropriately with the stressors. I think if you have a mom who's in your NICU and she comes to you and says, I'm just really having problems with breastfeeding, it would not be appropriate to say, well, my job's the baby, so you need to go talk to your mother-baby nurse. No. Everybody needs to help that mom be supportive in terms of breastfeeding. So getting that person connected with resources, picking up on things that are abnormal. So for example, if you're the NICU nurse and you happen to notice that your mom is sitting there in a rocking chair and the left leg is 3 times the size of the right leg, you need to let somebody know about that because you're concerned about a DVT in mom. These folks often need counseling and social services. You have to remember that some people are very reluctant to be attached to their baby because they're afraid the baby's going to die. And so they're reluctant. It's like, oh, I don't want to see her. I don't want to hold her because it doesn't look good. And so I think that's a really hard place to be. I think a lot of people blame themselves. If only I had done this, or it's because of me that the baby's here in NICU. And so there's a lot of guilt associated with that. We have a lot of issues with faith and spirituality in NICU. We talk about fetal care in NICU. So in NICU, there may be situations in which the outcome is pretty dire, but a lot of treatments and procedures continue. And a lot of NICU staff talk about that and how distressing that is, doing all these things to a little tiny baby that isn't likely to live. It's a high stress environment. I think a lot of people are very intrigued by NICU, but I also think it's a special kind of nursing. And unfortunately, people get burned out on it a lot. So let's talk about perinatal grief. So perinatal grief, perinatal death is it's a tough topic, and it can happen in utero. Can also happen after delivery. So NICU nurses and OB nurses are helping with both of this. Sometimes the baby dies at delivery. So if you have a baby that dies at delivery, or is stillborn, one of the key questions you wanna ask is, do the parents wanna see the baby? And sometimes they don't wanna see the baby right away. So what we usually do is we take the baby, bring him over to the warm room, and we try to kind of look, and we wanna kind of put them in a position that mimics what a baby would naturally appear. And so you usually will put their hands up towards their chest. And it's important to kind of talk through that. Neonatal death occurs in the first 28 days of life, and the same thing. We try to kind of remove all their tubes and things so they look more like a baby instead of a baby hooked up to all this stuff. Ideally, you know, you get the chance to say goodbye, but a lot of times you don't. And so parents will ask you, did the baby suffer? So I think that's a key question that parents want to know. When a baby has died somewhere, whether it was during the pregnancy or afterwards, it's really important to alert everyone else. What happens over and over again, very well-meaning people, the lab, the birth certificate clerk, somebody who got pulled from a different unit who doesn't know the story, they go in and talk to the patient and they have very sunshiny, and that is really offensive to the parents. So we usually post signs outside of the door. You might see a butterfly or a rainbow or a raindrop. There's different ways to notify people that patient had a loss. The other thing I want to tell you is those patients are sometimes on the med surg floor because parents may say, I don't want to be on the OB unit, and listening to other people with their babies crying and seeing all the pink and the blue balloons and having to see those babies in the hallway, it's very distressing. So they'll come and see you on the med surg floor where you're working because remember you didn't want to do OB, and now you've got an OB patient who's had the loss of a baby on your med surg floor. So we still do all the same care, we still do fundal checks, we still watch for all potential complications. Some moms, they want to keep the baby as much as they want, and some people don't want to see the baby at all. When we take the baby down to the morgue, some parents ask to have the baby come back up. So a lot of times we'll go down to the morgue, get the baby, and bring the baby back up to the room. So these are things that you do not want to say to people who've had a loss. At least you're young, you can still have other children. That doesn't take away from the identity of this particular child. You have to remember with babies, parents had a lot of dreams and aspirations for that child that are now unrealized. And I think the other thing to remember, you know, we talk about death, but you can have grief because I think about other things. So for example, you know, your baby has cerebral palsy, your baby has a heart defect and has to have multiple heart surgeries in the first week of life. That's a very traumatic thing to go through. And so you see all this stuff where, well, that was really successful and this person does, you know, great, but it doesn't diminish what you personally are going through with your own baby. At least you didn't know him or her yet. I think, again, moms, they've carried that baby for months and months and months. And getting the idea of thinking about what it's like to be a mom, what it's like to be a parent. It's a blessing in disguise. I hear that a lot. So glad it happened now rather than later. You know, it's a good thing that you delivered at 18 weeks, right? Totally the wrong thing to say, totally wrong. It's never a blessing. It's not a relief. And it's a very, it's a tough thing because again, there's some complications, something happened, and many times we don't know why. And that's a big question parents have, why did this happen? And our answer is, I don't know. God needed another angel in heaven. That is also, so I think we need to be really careful. There's questions about burial and whether you're gonna have a funeral for the baby. Some parents, quite honestly, don't have the finances to do that. They barely had enough to make ends meet for having the birth of the baby, but now to also consider funeral expenses. So we usually try to get them connected with social resources. There are some funeral homes who actually do discounted discounted services for people who've lost a baby, that the casket's much smaller, and things like that, so. And then, just because this situation kind of rode, the next pregnancy and delivery is not scot-free. It impacts future pregnancies and future delivery experiences. And it could be grief, but it could also be a NICU experience, because you may have a mom whose first baby was a NICU, and now she's worried that this baby will also be a NICU. So we do see a lot of anxiety and depression in moms. There's concern with bonding, and then this can also have a delayed grief response. And you see that a lot in nurses as well, because we have to. It's like you have to turn your emotions off. You can't deal with them at the time, and then they come out in really inappropriate times. And so I think it's important to be kind and considerate and understand that it's just part of the grieving response. So, all right, let's talk about something else. Denial, it's a wonderful